And it's my pleasure now to introduce Partners President and CEO, Dr. Gary Gottlieb, who's going to talk to us about healthcare transformation the next 5 years. Please welcome Dr. Gottlieb to the stage.
Good afternoon and welcome, and thank you so much for coming to this truly important 9th Connected Health Symposium. The ability to bring all of you together to think through how we can solve the challenges that are ahead of us is truly exciting. And I would say that the future, the 5 years ahead of us, the 10 years ahead of us, are filled with challenges, which means enormous opportunity for innovation. And so much of it is in the energy, in the minds of this room. So we will be begging for all of your help, not just those of you who work for Partners, but all of our partners and all of you who can become partners in this process together, because this is a major commitment to society that we need to take on together. You know, every day over the next 20 years, and looking in this room, not all of you are in this category, about 10,000 of us will be reaching the age of 65. So think about that as the landscape of healthcare ahead of us. And the number of people with chronic conditions is going to increase by more than 1/3 over the course of the next 2 decades. The healthcare expenditure data you've seen before you, look at the graph 1 or 2 more times as you listen to the politicians who are in and around us. If this goes unchecked, clearly our accountability to society also goes unchecked. Our ability to crowd out so much other good, despite the investments that we are making simultaneously, the challenges ahead of us are truly awe-inspiring. Over the course of the last several years, we've seen healthcare costs crowding out capital, crowding out wages, and becoming an extraordinary proportion of national healthcare expenditures overall. You know, to some extent, the reason that most employers tolerate increasing healthcare costs is because of the tax-shielded nature of healthcare premiums. And therefore, from their perspective, it's actually easier to pay for those premiums than to, in fact, increase overall wage base. But from earning dollar potential and the ability to participate in society, for individual wage earners, there is a trap in this overall, and their wages are being trapped out. And at the same time, capital is being caught from the perspective of creating new business, new innovation, and new opportunity. So there's little question. You know, we've had a number of exciting conversations about this over the course of the last 30 years. You know, the reason I started to get involved in healthcare management is when I was finishing my residency in psychiatry. It was in the early 1980s, and President Reagan had just passed TEFRA because we were at a time in which we saw healthcare costs skyrocketing. Healthcare costs had eclipsed 10% of the gross national product at the time. And the notion was that hospital costs needed to be changed, and we moved from cost-based reimbursement to prospective reimbursement under DRGs just around that time. And I was concerned that the people I cared for the most, people with brain disease, people who lived in the dust, the future of our healthcare system, would be imperiled if there were extraordinary cost-cutting opportunities. And we never realized those changes, although in each of the era beyond that, we have focused on some kind of attempt to rein in costs and at the same time improve the care that we provide. In the course of that period of time, there have been breathtaking advances, expansion of life expectancy, improvement of outcomes in cancer and in heart disease. At the same time, these costs imperil society. We're sitting in a country that's exceeding $15 trillion worth of debt, and that debt begins to crowd out other components of our ability to take care of those in need, to innovate, to invest, and to have a future overall. In every state in the country, the largest line item in their budget is Medicaid expenditure. In this state, it's a little larger because of the overall expenditures and investments we've made in other aspects, not just on the Medicaid side. And private employers, particularly small businesses, are screaming. There isn't one of us who doesn't live in a town in which teachers haven't been laid off or firemen reduced in their number because of retiree or municipal health care benefits overall. So therefore, the political pressure to act seems to be at hand, and we're seeing it at the state level and at the federal level. It is probably the loudest of all voices in the presidential debates we've been hearing, and at a state level here, the debate was pretty intense over the course of this summer. On the other hand, there could be tremendous effects in throwing out so much of the magnificent baby with the bathwater. So much of the advances that so many have at hand, particularly as it relates to severity of illness, prevention, and the opportunity to do greater good, could in fact be diminished if one focused on cost alone. And the healthcare economy has been a driver at a time in which manufacturing has left our economy and in which much of what we gained in terms of jobs and investment in financial services in fact turned out to be an illusion, and a very, very sad and frightening illusion. The healthcare economy and its driver in life sciences is probably the greatest corner of innovation and growth in the American economy, and it accounts for a substantial number of jobs in every local economy, and it stands for those at a time in which the rest of the economy on the employment side is frail and threatened. In Massachusetts, about 1 in 5 workers is employed in the life sciences or in healthcare. It's about 1 in 6 in direct healthcare delivery, and then another bunch who are in the life sciences related industry, and we are the leader in life sciences in the country. It's the driver of our innovation economy and a true differentiator in our knowledge economy. It's one of the things that's in fact protected us remarkably and allowed us to recover somewhat from the enormous hits that we took during the recession. It has also become a template for national reform. For those of you who aren't from Massachusetts, this is an environment that perceives itself as being progressive, and therefore we try a lot of things. And there are a couple of things that we've tried, one that related to coverage reform and another that relates to cost and overall payment reform over the course of the last 6 years. So Chapter 58, which was really the template for really the entry points of the Affordable Care Act, we're able to reduce uninsuredness in Massachusetts to a level that leads the country. Less than 2% of adults are uninsured, and less than 1/2% of children are uninsured. That is striking, it's remarkable, and it's an act of extraordinary civil justice. If there is a right and a civil right of the 21st century, it is access to health care and to education in a way that clearly crosses the spectrum. And in this regard, we've made substantial advances in this regard. But in 2006, like the beginnings of the criticisms around the Affordable Care Act, what we took on was coverage and access, and we didn't take on the cost components. So essentially, Chapter 224 that was passed on July 31st, the last day of the last session, basically took on costs. And it created an ability to create a cap. The cap is a soft cap in that it requires work plans and changes associated with it and an ability to do work as opposed to a trigger that would cause changes in prices or rate regulation overall. But if you take that cap, which is theoretically potential GSP, and I won't get into an argument with you as to who could in fact figure out what potential gross state product is. The Federal Reserve Bank in the United States has been unable with its economists to really determine in a fixed way what potential GDP is for the country. But if it were held at 3.6%, which is what the first couple of years of the law require, you can see that current growth rates of about 6% would exceed that remarkably, and the gap would increase substantially, which would create substantial pressures on trend. These are the environments that we face in looking at the healthcare around us. So additionally, this Healthcare Regulation Act, as well as critical components of the Affordable Care Act as they move forward over the coming decade, focus on movement away from transactional fee-for-service medicine to a variety of opportunities to focus on reducing total medical expense. And in reducing total medical expense, to try to create a different set of incentives. Incentives that theoretically focus on value, on shifting a substantial piece of risk to providers and provider groups in managing populations or episodes of care, and the ability to focus on the population that consumes the most resources, and to be able to move from ordinary, really transactional retail fee-for-service medicine to medicine that has a higher degree of cost and price sensitivity and therefore has different payment mechanisms associated with them. The paradigms that are being whispered are terms like accountable care organization, and I think that there were 1,200 people registered for this particular symposium and perhaps 785 definitions of accountable care organizations. I would tell you there isn't one of us who provides health care who doesn't want to be accountable. There isn't one of us who doesn't want to provide care. and we all are truly organizations. The question is how we're paid, what it means to be managing those populations, how we're organized, and then how patients who are the most important part of this and the populations who are pre-patients get access to the resources that we provide in a way that's defined by science, that generates information to be able to improve the care overall, and that is able to reduce this trend overall. That's moved towards models like shared savings, where providers and payers of the government share both up and downside risk overall, as well as global budgets that are imposed, really the beginning of disintermediating the insurance paradigm overall, and looking at episodes of care and trying to create a payment across a spectrum so that the transaction doesn't define the payment. All about coordination, about bringing these pieces together, about every piece of what you've been thinking about in this room, sharing information on a remote basis, sharing data to be able to inform the process, and being able to share the knowledge in a consistent way of what an individual has at risk or is going on overall. And we've seen a number of insurance changes overall, basically tiered and limited networks with higher copays and deductibles, a lot of cost shifting, basically moving more costs on and creating some cost burden on the shoulder of consumers. Tiered networks which differentiate providers based upon their price, that therefore allow consumers to become considerably more price sensitive than the insurance paradigm would allow overall. Co-ops among small employer groups, so that small businesses getting together to provide the insurance function with some administrative overhead and to be able to create community rating for their groups as opposed to suffering the consequences of having small numbers on the actuarial side. And ultimately, direct provider contracting. Walmart just announced a Center of Excellence contract with 6 large providers across the country to provide specialty care in a number of areas, including cardiac surgery. And that kind of disintermediation of payers becomes increasingly associated with transfer of risk to providers. This conversation is focused on so much of what needs to be derived from connections and connected health. First, coordination. And, many people who I call friends and whose opinions I honor say that 30% of what we expend on healthcare is wasted. None of them have been able to point to which 30% that is and where they're consuming those resources overall. But we do know that the transactional fee-for-service basis of medicine creates fragmentation. It disintegrates the care. We have magnificent physicians in our system and all over this country, magnificent nurses. But if they are functioning within their office, within the walls of their office, without clear coordination among the other components of the system, they will only use the resources that appear near to them and the resources that are expedient in solving the problem and will not be able to pass data. Even with the most sophisticated electronic medical records, we all know that one has to parse through records that electronically would be as thick as those giant records that we used to get in the emergency room at a VA hospital or in a public facility, where we're looking back in years and years and starting to query natural language to be able to find that information. Without the connectedness between the patient and his or her family and their circumstance, the provider on an ongoing basis, and a series of other providers in a way that's enforced by payment but connected both electronically and programmatically, we will fail. It is the only opportunity for more effective and efficient reduction in total medical expense with higher value and better outcomes. Our measurement has been embarrassing. We are probably at chapter 2 of a 50-chapter book in being able to look at outcomes that have anything to do with what it is that patients want. Most of the data that we have look at really at process measures that are distant proxies for outcomes overall, and the interventions that we pursue based upon science sometimes are interventions that science seems to be telling us are better at the cellular or the potential survival level, but not necessarily associated with the outcomes that individual patients want from their cancer treatment, from their knee surgery, or for an intervention associated with pain. And that measurement of outcome and its association with specific inputs and the cost of those inputs is ultimately the value that we're seeking overall. And clearly, we need to seek to provide better quality and be able to do it more efficiently. Is it somehow that the beginning of the 21st century with crossing the quality chasm to err as human was a wake-up call? We didn't know that we were making errors or that we weren't achieving the highest degree of quality. And the fact that we've put ourselves and made ourselves accountable in that regard has reduced errors remarkably, has saved lives and will continue to, but needs to be invested in consistently and needs to be at the heart of this discussion. This discussion cannot be about cost in the absence of, first and foremost, about quality, safety, and improvement of the human condition. And if we focus on cost, we will do very much what we did to the field that I come from. To focus on cost in psychiatry has told us that we've wanted to go from 8.5% of commercial premium in the early 1990s to 2.5% or less of commercial premium now. And at the end of the day, people still have brains, and they still live in circumstances in the society that cause them stress. And without the focus on improvement in that quality and that investment, we've lost and fragmented our way. And now when we're taking global risk, we see that all the risk is in those people with behavioral health and substance use disorders co-mixed with their medical disorders and need to start to reinvest. That is a problem that we cannot reface with every condition and every circumstance. So at Partners, our strategic focus in preserving our mission, which is this precious mission of being able to really bring the best and the brightest to care for the sickest and the neediest among us, to use science to inform our care, to train those who are part of our future, and to invest our communities, those who need us the most here and around the world, is to really try to be a leading provider of population-based care. But we've chosen to focus where we believe the money is and where the opportunity is, at high risk and high cost patients. The 10% of the Medicare population that consumes 70% of the population, the 5% of commercial populations that consume 50%. If we can deal with that high risk and do that more effectively and more efficiently and create savings there, it'll take the pressure off the transactional savings that are necessary elsewhere and allow us a glide path to reinventing, managing those episodes and the rest of that care better. If we can deal with that piece, we'll be doing it humanistically, we'll be doing it by science, we'll be doing it better for our patients, it'll be patient-centered around those circumstances. It's where we need the data the most, it's where we need remote health and telehealth the absolute most, but it's also where the greatest opportunity is to do the greatest good in the context of an aging and chronically ill population. And we also want to provide episodes of care in a way that's fundamentally different and better than we ever have been before, to exploit the infrastructure of our system. 70% of what we do in a system like Partners is referral business. We have 2 magnificent academic medical centers who the only thing that they should be providing most efficiently is care that can't be provided in other venues and using their great expertise in their local venue. And therefore, we need to be able to put together, to go from the transaction, from interacting with a magnificent physician to interacting with an entire episode of care where that specialist has some financial skin in the game to help to coordinate that episode, whether it's a year of caring for diabetes, a coronary artery bypass graft, a knee replacement, over the course of that period of time with a price that can be price sensitive and appropriate to those who refer us from other networks and to patients as well, and still be able to provide even better excellence and value overall. And to do it in a way that we measure, but all around patients and their families. For us, there are kind of 2 sets of approaches to looking at our clinical strengths to try to change what we do, to obviously focus on integrated and patient-centered care, and to increase affordability. So both unit costs as well as the number of units is critical to be able to monitor, to be able to focus on, and that requires deep knowledge of the populations we're responding to, as well as the patients we're currently taking care of. It requires very, very sophisticated registries of the populations we serve, as well as the risk factors to be able to create first tertiary and secondary prevention, and then ultimately, when we have stable populations over longer periods of time, primary prevention overall. And it all has to be related to performance metrics and outcomes that truly matter to people overall. And clearly, those relate to our investments in science and the translation of them into better clinical care, being able to focus on our communities where the expense and the need will continue to grow, particularly with the polarity of income distribution and, frankly, the absence of any social safety net in this country that's real or profound. Much of the social safety net that relates to food and housing security actually sits somehow juxtaposed to urban medical centers rather than within other venues, and therefore it's going to be on us to help to be able to coordinate those components as well. In this system, we have a broad base of providers and an extensive system. We have 2 academic medical centers, the Mass General and the Brigham and Women's Hospital. We have a half a dozen community hospitals. We have rehab hospitals in the Spalding's network, skilled nursing facilities, psychiatric facility, specialty care. But we have a base of primary care physicians, primary care nurses, providers of other disciplines. Each of these are magnificent, but if they operate in silos, they really will continue to promote this efficiency. They'll promote singular excellence, but no value in terms of overall outcomes, except for a transactional experience. And that kind of fragmentation that has been reinforced by the traditional fee-for-service model is not part of the future over the course of the next 5 years. We're trying to travel a path in which there's clear pressure, as I mentioned to you, to reduce the cost trend. We reopened our contracts and took lower increases in our rates and moved ourselves into risk contracts, the last of which was mentioned in today's paper contract that we announced today with Harvard Pilgrim. We gave back about $345 million over these contracts in terms of rate increases because essentially we knew we had to put pressure on ourselves to be able to continue to reduce costs. And we ultimately, in January 1st, moved almost in a switch to taking risk for about 500,000 people, including 50,000 in a Pioneer ACO. That creates changes to the structure of the system and to that kind of coordination and requires us to be able to fundamentally transform ourselves, make investments specifically in population health management, redefining our primary care practices so they are in fact patient-centered medical homes, patient-centered medical neighborhoods, and villages around the community hospitals that we serve to get the right care into the right place, but to tie the information to those local places and to create an internal performance network for our physicians, a new kind of paradigm around incentives, which we've now started to roll out, that focuses on embracing our strategic investments, like our patient gateway, to get that up to 100% utilization, like connected health with telehealth, and be able to use a variety of connected health parameters to be able to manage specific episodes and conditions like diabetes and congestive heart failure, and having specific quality outcomes. And the smallest part, about 30% of the overall dollars, focused on more efficient utilization. So to drive a set of incentives by our values, not the insane parameters that were created in the early 1990s when all about cost and creating barriers to access was driving the way in which we tried to manage costs at that period of time. And the first piece of this is to first really coordinate and provide care with intensive care managers to those people at greatest risk, to reduce that cost that the most expensive and high-risk patients absorb, to enhance access to lower cost specialty services, so places where we have shortages, to do asynchronous consultation in dermatology, infectious disease, or in cancer, to do that regionally in such a way, virtually and electronically, so that we have reasonably instantaneous access within the practice to consultation or the minds of those specialists, and not the need to create further intervention or further cost, and clearly to continue to incent that in a way that's different, and to try to get cost trends that are closer to GDP. This means that so much of this is on you, and I could probably just finish the talk now and you guys can come up with the solutions. But so much of what we need to do is about collaborating with patients, being able to get to understand who the population we serve is from a broad perspective of phenotypic data that are available about the population, about individuals, and about their care. The more that phenotypic data is available to us, the more that we can inform the registries that we create to be able to prepare for who's at need for an intervention or who might be at need because of who they are and what they bring to the healthcare environment, or how it is that we keep them out of the healthcare environment overall. It's not just patient portals, it's so much more. Collaborate with patients to be able to understand that new venues of care are more appropriate, that we can do front-end care and primary care in people's homes, or provide substitutes for acute hospitalization and the ICU in people's homes ultimately with connected health, and be able to monitor data, and perhaps a sprinkling of the spectacular people who do home health and other resources. We need to collaborate with each and every referring physician. It can't just be an episode as a step up from a transaction. It has to be an in and out portal so that there's continuous care, whether the person comes from here or comes from Dubai, in order to be able to make certain that what it is that we invest is a long-term investment when that patient gives us the privilege of participating in their care, and that continuity creates that set of efficiency, and that requires continuous access to data as well as data that may be in real time achieved from monitoring patients overall. And we need to provide provide tools to create the interstices. We are so far away from single sharing of information, and the interfaces are so slow, so expensive, and so inefficient. So we need to be able to make these communications considerably swifter and make those investments overall. Clearly, on the population health side, we need to do a much better job in identifying who the cohorts of people we're caring for are and what differentiates them. This is all about ultimately going from the top to the bottom here. It's really creating precision medicine. If precision medicine is both understanding a population, ultimately down to understanding an individual, and understanding an individual with her genome as well as her phenotype, the ability to put together data about an individual, about his or her risk, to be able to use those registries to inform how practices are created, and then to be able to quickly identify people who are in need of consistent communication, follow-up, and connectedness, to be able to do that in a way that's efficient and patient-centered while we're managing those people, ultimately also leads us to the combination of those phenotypic data that are rich, the ability to manage giant amounts of data, because if we're going to bring together real phenotypic data for precision medicine, that includes the digits of all the imaging that we're doing, as well as biorepository, genomic, and other biomic-related data. But the opportunity is real, and it's rich. These building blocks are here, and they're disseminated. Much of the knowledge already exists to inform this development. And the greatest opportunity is created by the substantial pressure that the downward pressure on costs overall creates for this kind of innovation. Each of these steps requires a new innovative solution. Each one is a startup. But at the same time, those being melded together will give us this opportunity. Thank you very much.